Thank you very much. We know about acute pericarditis. Frequency in the United States is approximately 1 in 1,000 hospital admission by the book of Spodek. We know the manifestation, the etiology, most common is the idiopathic form and viral, PMR, post-myocardial infarction, PPS, decreasing atrial frequency, and the treatment of acute pericarditis. Usually, if we have the etiology, we know about it, we treat the etiology, and drugs as non-steroidal and non-steroidal drugs and corticosteroids. The recurrent rate after the acute attack is between 15 to 32%, with the most common cause is the idiopathic and then decreasing order of frequency, viral, PPS, and post-myocardial infarction. Treatment the same as the treatment of the acute disease. Some doctors advocate the use of immunosuppression, and some go as far as pericardial. The first application for the efficiency of COlchicine for recurrent pericarditis was in '87, and later the editor by the Spanish group from Barcelona with Baez de Luna. They described 3 patients who suffered from recurrent pericarditis despite treatment with conventional treatment, including corticosteroids. And on the basis of the efficiency of COlchicine for recurrent polycirrhosis, FMF, they began COlchicine 1 milligram a day with tapering off the corticosteroids 2 to 6 months after the combined therapy was begun. And during a follow-up of maximal of 41 months, no recurrences were documented. The same group in 90 in circulation described their experience in one patient with recurrent pericarditis. Again, the same, no cure with the conventional treatment, COlchicine 1 milligram a day, with tapering off the corticosteroids 2 months after the combined therapy was begun, and during a follow-up of 54 months, no recurrences were documented. Our group from Tel HaShomer described in the American Journal 4 years later our experience of 8 patients of recurrent pericarditis, 5 idiopathic, 1 chest trauma, 2 post-cabbage, total 26 attacks of pericarditis with the conventional treatment, corticosteroids for the all patients, and we began COlchicine in average dose of 1 milligram a day with tapering off 2 months after the combined therapy was begun, and during a follow-up of 43 months, no recurrences were documented. What we know about COlchicine, some history, 6th century AD, first recommended for pain of articular origin, 763 introduced for the therapy of acute gout, and 820 alkaloid was isolated. How it works, the COlchicine, we know it binds to tubulin, the polymorphonuclear, decrease metabolic and vacuolytic activity, inhibition of nutrition into inflamed area, and break the cycle of inflammatory responses. We know about the efficiency of COlchicine as a prophylactic uses, sometimes for acute gout and chronic gout and all the other here. We don't know the exact mechanism how it helps for patients with recurrent pericarditis, but what we know from the data I gave you and the data I will give you shortly, that the side effects of COlchicine in those doses of 1 milligram a day are very few, and most of the patients didn't need to stop the medication. Precaution, careful use of impaired renal function, careful monitoring of side effects and blood tests, and avoid negative drug interaction. We have to do a dose adjustment according to age and renal impairment, and we need to remember, especially 2 drugs, the HMG-CoA reductase inhibitor and the macrolide antibiotic for a drug interaction. The biggest trial ever was published by our team with the American team, David Spodek, in Circulation 98. We described 51 patients with recurrent pericarditis, most of them idiopathic, 33 patients were idiopathic recurrent pericarditis, and 18 patients were secondary pericarditis, most common post-thoracotomy. Under the conventional treatment, all the 51 patients suffered from 187 recurrences of pericarditis, and the metal interval between recurrences was 3 months. We started COlchicine in average dose of 1 milligram to all the patients with tapering off the corticosteroids 2 to 6 months after the combined therapy was begun, and we are dealing here with 1,004 months of COlchicine treatment and 2,333 months of follow-up. And what we can tell, that 7 out of 51 patients, 14%, presented with 10 new relapses on colchicine treatment. We have to remember that most of them, when corticosteroids were stopped, and the other in other cases. The recurrences were generally minor. Colchicine was stopped in our trial in 39 patients, sometimes by the patient himself, sometimes by the order of the physician. 14 out of 39 patients, 36%, presented with 70 new recurrences, 10 out of 70 during the first month after colchicine stop, and this is why we know today that like in corticosteroid, in colchicine, we are doing tapering off after 1 year of treatment. 5 out of 70 during the 2 to 6 months after colchicine was stopped, and the others in the second half of year after colchicine was stopped. Attacks were generally minor. The first clue for corticosteroid and recurrences were documented in this trial, and we'll speak about this point later. And comparison of the interval between crises before, during, and after colchicine therapy yielded a significant increase in all intervals. Globally, colchicine prolonged the intervals between relapses from 3 months to 43 months, with a significant difference, of course. And the conclusion in 1998 was that colchicine is an effective and safe drug for long-term prevention of recurrent pericarditis. The question was, what about corticosteroid? So pre-treatment with corticosteroid attenuates the efficacy of colchicine in preventing recurrent pericarditis. A multi-center all-case analysis were done and published 6 years ago in the European by a very brilliant student, Galit Artom, today in Maccabi Shirotei B'rut. And what she did, the aim of the study was to aggregate all data available, investigate the efficacy of colchicine, and the hypothesis was that pre-treatment with corticosteroids may attenuate the beneficial effect of colchicine. Multi-center all-case analysis, even Lebanon took part with Israel in this trial. The inclusion criteria was 2 or more relapses of pericarditis, therapeutic trial of colchicine, and complete documented follow-up. We left with 119 patients, age range 8 to 83 years. The results. We know that before colchicine, all patients, of course, had recurrent pericarditis, and we can see that during colchicine treatment, only 80%, more male than female, had attacks of pericarditis, and after colchicine treatment, 30%, again, more male than females. Corticosteroids, 88 out of 119 patients were treated with corticosteroid prior to initiation of colchicine treatment, and differences in the percentage of patients with relapses during the treatment with colchicine and after its discontinuation as a function of a previous corticosteroid treatment. You can see that during colchicine, more relapses in patients who were treated with corticosteroid prior to the treatment of colchicine, and much more after. If we see number of relapses per patient and duration of colchicine treatment comparing patients with and without previous corticosteroid treatment, we can see a significant difference between the corticosteroid treatment and no corticosteroid treatment, and relapses per patient post-colchicine the same, a significant difference between the two groups. So the conclusion can be that pre-treatment with corticosteroid attenuates the efficacy of colchicine and exacerbates and extends the course of recurrent pericarditis. But if we look at this patient before treatment with colchicine, the same significant difference, the relapses per patient before treatment. So the question is, past corticosteroid use may be simply a marker of a higher tendency to relapse rather than a cause of it. We did a correlation, regression analysis. There was no correlation between the numbers of relapses per patient before, during, and after colchicine. And in logistic regression, only male gender and much more previous corticosteroid treatment were an independent predictor for recurrences on colchicine and after colchicine treatment. And this was the first publication who emphasized the problem with corticosteroid treatment to those patients. Colchicine is highly effective in preventing new relapses in patients with recurrent pericarditis. We know about corticosteroids, increased risk of recurrences, severe side effects. Colchicine favorable efficacy, fewer side effects, and when you consider colchicine in those of 1 milligram a day as the first drug of choice for recurrent pericarditis. In those days, I'm talking about 2004 and 2005, we had a lot of data for the efficiency of this drug for the disease, and we were lucky to be invited by Professor Bernard Mesh to be, all of us, in the first line here, to be in the task force and to write the guidelines for pericardial disease. And the conclusion of our team were that in recurrent pericarditis, colchicine is numero uno for this disease. In acute, it was 2A, but I'm sure Professor Elliott that nowadays we are sitting again, it will be higher than 2A. And I will show you why. You can see here Massimo and I in Stadium Olimpico of Torino. We came to see Juventus in the Serie B, but Massimo took the issue of colchicine and pericarditis to Serie A, and this is the first trial Massimo did, the COP trial. It's the first randomized trial on the use of colchicine to prevent recurrences, also in patients with acute pericarditis. The COP trial is an open-label randomized study where 120 patients with acute pericarditis were randomly assigned to conventional treatment alone, 60 patients, or conventional treatment plus colchicine, 60 patients. No patients were lost on follow-up, and all were analyzed for outcome. Conventional treatment was aspirin or non-steroidal inflammatory drugs. Corticosteroids were only given in patients with contraindication to aspirin or non-steroidal. Here we can see the result of this study. The primary endpoint was the recurrent rate. Colchicine reduced the recurrent rate at 18 months down to 11% and was also able to reduce the symptom persistence at 72 hours as it can be observed in patients with acute gout. Drug withdrawal was recorded in about 8% of cases due to diarrhea. Thus, in this study, we need to treat 5 patients with colchicine in order to prevent 1 recurrences. In multivariate analysis, again, corticosteroid therapy was an independent risk factor for recurrences. Here we can see patients treated with colchicine have a longer event-free survival, as we can see in this figure. Another trial, the CORE trial, colchicine for recurrent pericarditis, is an open-label randomized trial on the use of colchicine in addition to conventional treatment in patients with the first recurrences. 84 patients with recurrent pericarditis were randomized to receive conventional treatment, 42 patients, or conventional treatment plus colchicine, 42 patients. No patients were lost. All patients were analyzed for outcomes. The primary endpoint was the recurrent rate. The main results are reported here. Patient treated with colchicine had a lower symptom persistence at 72 hours, and colchicine halved the recurrent rate at 18 months. Thus, we need to treat 4 patients with a first recurrence in order to prevent a subsequent recurrences. Again, corticosteroids is an independent predictor for recurrences. You can see the event-free survival with the results we mentioned before, and another trial was done by Massimo. Corticosteroids for recurrent pericarditis, high versus low dose. It's better if we give corticosteroid to those patients to give in a low dose treatment because we have fewer severe side effects, fewer recurrences, and less hospitalization. As was published by us, here you can see part of our team, Antonio Boccazzo, Alida, and David Spodek from the state, and sorry. And you can see here one of the articles we published in the Nature Cardiovascular Medicine. Again, if we give corticosteroid, we should give in a low dose to those patients. Some words for colchicine for large pericardial effusion. This is one of the case reports. We have only case report on this issue, and I'm sure one day we can do a big trial on pericardial effusion. And what we have to do, as our friend did and we did, we know that colchicine may be effective in the treatment of large pericardial effusion when therapy with non-steroidal anti-inflammatory drug and or corticosteroid fails, but yet we need larger trial. PPS, a trial we did several years ago in Baileyson with Professor Widner, and in this trial we have to remember backwards the PPS is a relatively common complication following cardiac surgery, 10 to 40% of patients. Non-steroidal anti-inflammatory drugs, corticosteroid, COlchicine, are reported for treatment in anecdotal reports. No drug definitively proven to be efficacious for this prevention. What is really PPS? We are dealing with a spectrum of different degrees of pleuropericardial involvement, from asymptomatic effusion to cardiac tamponade, massive pleural effusion, and we have to be aware of all forms of cause. Diagnostic criteria for PPS will be based on the presence of at least two criteria of what is written here: fever, pleuritic chest pain, friction or pleural effusion, new or worsening pericardial effusion. And in our preliminary trial we did in Bellison, we did this trial on 111 patients, and we saw a trend towards patients who were treated with COlchicine after the surgery to less PPS. Of the 120 patients who completed the study, 42% received COlchicine, 57% placebo. PPS was diagnosed in 90 patients, 70%. Now, 5 of the 47 cases, 10% in the COlchicine group and 21% in the placebo group. We don't have a significant difference, Professor Goldberg. I'm not talking about the p-value, but we have a trend, and we publish it with our German friends in the Hertz journal. But what we did in Italy, in multi-center, 6 centers in Italy under the supervision of Massimo COlchicine for prevention of PPS, the COPS trial, and this was published in the European Heart Journal lately. And the only difference between the trial was that here we have much more patients, 360 patients. The results are very, very similar. Primary endpoint PPS at 12 months, secondary endpoint hospitalization, cardiac tamponade, constricted pericarditis, or recurrent pericarditis. And we can see the inclusion and exclusion criteria, and the results show that no difference between the groups. And here you can see the PPS at 12 months. Again, you can see the same results as we had in Israeli, in Bellison, 21% compared to 9%, placebo compared to COlchicine, and secondary endpoint with a significant difference, as we can see in these COPS trial results, with NNT of 8, and PPS event-free survival, the same result as we had before, and safety, side effect, and drug withdrawal. We can see that severe side effect, no difference, gastrointestinal, no difference, overall, no difference, and the conclusion is that COlchicine is safe and efficacious in the primary prevention of the PPS and its related complication. In the COPS trial, COlchicine half the risk of the PPS, like in the trial before, following cardiac surgery, and as I told you, class 1 indication for recurrent pericarditis, class 2A, and I think today it will be much higher than class 2A of this drug to this disease, with those amazing results, especially in the Mediterranean area. Thank you very much.